Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very, very handy in your line of duty. So I welcome you all to part 132 of our Pharmacotherapy MCQ series, Majoring in Infectious Diseases. And the first question reads, Mr. KJT, a 30-year-old male patient weighing 98 kilos, presents to your chest clinic where he is diagnosed with pulmonary tuberculosis. He has no known past medical history and currently takes no medication, neither does he take any over-the-counter medications, and he doesn't take any herbal medicines either. And you establish he is allergic to codeine. His calculated creatinine clearance is 94 mLs per minute, 1.73 meters squared, and the LFTs are within normal limits. My question to you is, which of the anti-TB regimens listed below would be the most appropriate for Mr. KJT's therapy now? Would you use Isoniazid, Rifampin, Pyrazinamide, and Ethambutol twice weekly for 9 months? Or would you administer Isoniazid, Rifampin, Pyrazinamide, and Ethambutol daily for 6 months? Or would you settle for Isoniazid, Rifampin, Pyrazinamide, and Ethambutol daily for 4 months, followed by Isoniazid and Rifampin daily for 2 months continuation phase? Or D, would you settle for Isoniazid and Rifampin, Pyrazinamide, and Ethambutol daily for 2 months, followed by Isoniazid and Rifampin daily for a 4-month continuation phase? I'll give you 10 seconds to choose the correct answer. I would settle for option D and administer Isoniazid, Rifampin, Pyrazinamide, and Ethambutol daily for 2 months as the intensive phase, followed by Isoniazid and Rifampin daily for 4 months as the continuation phase, which makes answer D the correct one. Now, I choose that because the patient has no underlying reasons not to receive the preferred treatment regimen, which is D. I would like to emphasize that answer C is incorrect because it states that a 4-month intensive phase and a 2-month continuation phase should be used, which is the reverse. Then answer B is incorrect because it involves using all the 4 medications for 6 months, which is not in line with any guidelines quoted out there. And then answer A is incorrect because it's using all the 4 medications for 9 months, as well as being twice weekly, which is not recommended in any guidelines. Let's move to the next question, please. And it reads, Mr. GPM, middle-aged male patient weighing 75 kilos with the HIV-TB co-infection, presents to your HIV comprehensive care clinic. He is yet to be initiated on highly active antiretroviral therapy. So my question to you is, which of the regimens listed below would be the most appropriate for his continuation phase of TB treatment? Would it be Rifampin at a dose of 600 milligrams and Isoniazid at 300 milligrams daily, or would it be Rifapentine 600 milligrams and Isoniazid 900 milligrams once weekly, or would it be Rifapentine 300 milligrams and Isoniazid 900 milligrams twice weekly, or would it be Rifampin 600 milligrams and Isoniazid 900 milligrams twice weekly? I'll give you 10 seconds to choose the correct answer. I would settle for A and administer 600 milligrams of rifampin and 300 of isoniazid daily. Remember, intermittent TB treatment, that is the once weekly or twice weekly or thrice weekly dosing treatments, may be considered in several cases, particularly if a patient is at low risk of relapse and is HIV negative. Now, twice weekly therapy with rifampin and isoniazid is not recommended in co-infected patients due to an increase in the risk of rifampin resistance, and that makes alternative D incorrect in my opinion. I'd also like to add that Rifapentine, while often substituted for rifampin in co-infected patients, is not recommended twice weekly either, for the same reason as I've just mentioned above, and that makes answer C incorrect. And Rifapentine and isoniazid once weekly are not recommended in patients with HIV. That makes answer B incorrect as well. I'd just like to remind you that daily treatment with either rifampin or Rifapentine and isoniazid is recommended to avoid recurrent disease and to minimize rifamycin resistance. So that emphasizes why answer A is the correct one. And I would like you to note that in the event that a co-infected patient does not receive antiretroviral treatment for HIV, a continuation phase of 7 months is recommended over 4 months for drug-susceptible pulmonary TB. Remember that. Let's move to the next question, please. And the next question reads, WKL, a 36-year-old clinical nurse, does a tuberculin skin test whose results are greater than 5 millimeters. He does a T-spot test which confirms he has latent TB, abbreviated as LTBI. He is hypertensive and he takes lisinopril 5 milligrams once daily, ibuprofen 400 milligrams PRN when in pain up to 3 times a day, and he desires to be treated for the newly diagnosed latent TB infection. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. WKL now? Would it be Rifapentine 600 milligrams and isoniazid 300 milligrams once weekly for 3 months, or would it be Rifampin 600 milligrams and Pyrazinamide for 2 months, or would it be Isoniazid 300 milligrams for 9 months, or would you settle for Rifampin 600 milligrams for 9 months? I'll give you 10 seconds to choose the correct answer. I would opt for Isoniazid 300 milligrams for 9 months. Now the preferred treatment option for LTBI is Isoniazid at that dose I've just quoted, 300 milligrams for 9 full months. That makes answer C the correct one and makes answer A incorrect. Now this patient has no factors that would warrant his trying another regimen such as Rifampin, making answer D and B incorrect. I would just like to emphasize that Rifampin and Pyrazinamide are no longer recommended because of an increased risk of hepatotoxicity, making them unsuitable choices for LTBI prophylaxis. That makes answer B incorrect. Let's move to the next question, please. And it reads, 7 days after initiation of LTBI treatment, Mr. WKL returns to your accident and emergency with a chief complaint of a bad reaction to Isoniazid with a severe case of hives. He declines to continue this drug. So my question to you is, which of the regimens listed below would be the most appropriate therapeutic switch in this clinical scenario? Would you change to Rifapentine 600 milligrams and Isoniazid 300 milligrams once weekly for 3 months? Or would you change to Rifampin 600 milligrams and Pyrazinamide for 2 months? Or would you continue Isoniazid 300 milligrams twice weekly for 9 months? Or would you change to Rifampin 600 milligrams once daily for 4 months? I'll give you 10 seconds to choose the correct answer. I would recommend a switch to Rifampin 600 milligrams once a day for 4 months. Now this patient had a reaction to Isoniazid. Therefore, a reasonable alternative would be treatment with Rifampin for 4 months, which makes answer D the correct answer. Now Rifampin has several drug interactions and the patient must be cautioned not to begin a new medication without first determining whether Rifampin will react or interact with it. The patient only takes lisinopril and occasionally ibuprofen, so that is not an issue. There will be no drug-drug interactions there of much significance. Now, using an intermittent regimen containing Isoniazid, that is C and A, would not help with the reaction. So those would be wrong answers. And in addition, the dosing is incorrect in those two answers, C and A. Then I would like to add that answer B is incorrect because of the increased risk of hepatotoxicity with Rifampin and Pyrazinamide co-administered together. Let's move to the next question, please. And it reads, Mr. AGM, a 30-year-old male HIV seropositive patient, is diagnosed with active tuberculosis at your comprehensive care clinic. He currently takes Rifapentine at a dose of 150 milligrams, Isoniazid at 300, Pyrazinamide at 1500, and Ethambutol at 800 milligrams. He also takes 400 milligrams of raltegravir orally twice daily, alongside a co-formulated form of emtricitabine and tenofovir, 200/300. Then you are told that 30 days after initiation of the intensive phase of pulmonary TB treatment, he returns to the comprehensive care clinic for a follow-up appointment. This time he has a chief complaint of blurred vision. The TB medication is taking its toll. And the HIV consultant establishes through further testing that AGM has lost his ability to detect color green. So my question to you is, which of the following medications is the most probable cause of this visual disturbance? Is it Ethambutol, Pyrazinamide, Rifapentine, or Isoniazid? I'll give you 10 seconds to choose the correct answer. Ethambutol it is. Now, the most serious adverse effect associated with ethambutol is optic neuritis. And this condition may affect both or one of the eyes, causing blurred vision and a decline in visual acuity. And it can cause a patient to be unable to detect the colors red and green. So that makes answer A correct. I'd like to add that Rifapentine can cause anterior uveitis, an inflammation of the middle layer of the eye. That may also lead to blurred vision. However, the inability to detect green or red is not likely with Rifapentine toxicity, and that makes answer C incorrect. Then Isoniazid and Rifampin are not known to contribute to vision problems, and that makes answers D and B incorrect. Let's move to the next question, please. It reads, BMW, a 47-year-old patient, presents to your accident and emergency department complaining of weakness, fever, and a 3-month progressive productive cough. It has lasted for pretty long. There's a social history as follows. Lives with his spouse. He migrated from a country with a high TB burden or incidence rate slightly over a year ago. His profession is construction work. Some of his pertinent vital results include a heart rate of 80 beats per minute, a respiratory rate of 22 breaths per minute, systolic blood pressure of 110, diastolic 62, and a temperature of 99.2 degrees Fahrenheit. On physical examination, the physician reports him as being a thin Asian male who looks older than the recorded age, and the other exams are within normal limits. A chest exam is done, and it shows decreased breath sounds bilaterally at the apices. A chest X-ray is done, and it shows a bilateral apical infiltrates with no cavitation. The team goes ahead to do quantiferon, that is the interferon gamma release assay test, which turns positive. This is a specific test for MTB. And a sputum is sent for gram staining, and acid-fast bacilli are noted. It's positive for AFB, and that leads towards thinking of MTB as a cause of this infection. Some of his pertinent labs are the HIV test turns negative, the electrolytes are within normal limits, the BUN and the creatinine are 28 and 0.9 respectively. So in my opinion, that BUN is slightly elevated. The ALT is 33, the AST is 44, and BMW is masked and placed in respiratory isolation pending further workup by the team. So my question to you is, which of the tuberculin skin test results listed below would be considered sufficient to prompt follow-up radiographic testing to help rule out pulmonary tuberculosis if the patient remained asymptomatic? Could it be 11 mm in a 20-year-old college student? Would it be 8 mm in a 40-year-old patient with type 1 diabetes mellitus? Or would it be 7 mm in a 50-year-old patient with chronic renal failure? Or would it be 6 mm in a 4-year-old household contact of a patient with pulmonary tuberculosis? I'll give you 10 seconds to choose the correct answer. So D would be the correct answer. 6 mm in a 4-year-old household contact of a patient with pulmonary TB. Now, a reactive TB skin test indicates infection, but must be balanced with clinical factors such as induration of positive test, documented exposure, size of induration, to determine the risk of developing pulmonary disease. Now, the patient in case D had recent contact suggesting shorter duration of infection, and this patient happens to be a child. So both of those put this patient at a higher risk for developing disease, and the size of induration is less important in this case. Now, for the patients in alternative A, B, and C, the length of duration is unknown, and therefore the TST induration cutoff to prompt further diagnostic testing is larger than those specified there. Let's move to the next question. And it reads, which of the regimens listed below would you recommend for BMW in the above case now? Would it be Isoniazid, Rifampin, and Pyrazinamide administered thrice weekly? Or would it be B, Isoniazid, Rifampin, and Pyrazinamide administered daily? Or would it be C, Isoniazid, Rifampin, Pyrazinamide, and Ethambutol administered thrice weekly? Or would it be Isoniazid, Rifampin, Pyrazinamide, and Ethambutol administered daily? I'll give you 10 seconds to choose the correct answer. I would settle for D, Isoniazid, Rifampin, Pyrazinamide, and Ethambutol administered on a daily basis. Now, for drug therapy is needed or indicated because susceptibility or resistance is unknown in this particular case, along with the unknown immigration status. The resistance might be higher or lower. We are not informed. Now, preferred initial therapy is daily administration and not intermittent administration, especially before the susceptibility results are known. So I would go for D. Let's move to the next question, please. And the next question reads, which of the antimicrobial agents listed below is least likely to require dose adjustment in a patient with renal insufficiency? Could it be streptomycin because it's excreted renally? Or would it be ethambutol, predominantly excreted renally? Or would it be rifampin? Or would it be pyrazinamide because the active metabolite is excreted renally? I'll give you 10 seconds to choose the correct answer. So rifampin would be the correct answer. I would just like to mention that pyrazinamide is metabolized to an active metabolite which is excreted in the urine, and may cause adverse effects if it accumulates in the body due to renal issues. Then ethambutol and streptomycin are primarily excreted in urine, so there would be issues there also in case of renal insufficiency. Let's move to the next question, please. And the next question reads, which of the following medications, if added to a regimen or to the regimen of a patient undergoing treatment for active pulmonary tuberculosis, would merit substituting rifabutin for rifampin? Would it be A, darunavir, or B, simvastatin, or C, methadone, or would it be D, warfarin? I'll give you 10 seconds to choose the correct answer. So darunavir would be the best answer. Now remember, warfarin and anticonvulsant doses or drugs such as phenytoin and carbamazepine may be adjusted via INR and serum concentrations respectively. And some statins such as pravastatin and rosuvastatin do not interact strongly with rifampin. Now, rifampin's interaction with protease inhibitors is much more profound and will lead to subtherapeutic antiretroviral concentrations in the serum, reducing efficacy in the management of HIV infection. Now, rifabutin should be used with the protease inhibitors, typically at a dose of 150 milligrams given daily, with PIs and with all other strong CYP inhibitors. Let's move to the next question, please. And it reads, during Mr. BMW's intensive phase of pulmonary TB treatment, his ALT increases to 6 times the upper limit of normal, that is abbreviated as ULN, despite remaining asymptomatic. My question to you is, which of the following would be the next best course of action in Mr. BMW's case? Would you choose to discontinue all TB drugs and restart the drugs gradually when ALT declines to less than 2 times the upper limit of normal, beginning with pyrazinamide? Or would you discontinue all the TB drugs and restart the drugs gradually when the ALT declines to less than 2 times the upper limit of normal, beginning with rifampin? Or would you discontinue rifampin and resume rifampin when the ALT declines to less than 2 times the upper limit of normal? Or would it be D, continue the current therapy and repeat liver function tests, the LFTs, in 30 days? I'll give you 10 seconds to choose the correct answer. B is the correct answer. I would discontinue all the TB medications and restart or rechallenge gradually when the ALT declines to below 2 times the upper limit of normal, and I would reinitiate starting with the rifampin. Now, an increase in the transaminases to 6 times the upper limit of normal suggests drug-induced hepatotoxicity. And we know that rifampin is an extremely important component of any efficacious drug therapy, but is also the most likely agent to cause hepatotoxicity. Reintroduction of drugs should start with Rifampin, followed by drugs in decreasing order of hepatotoxicity, i.e., followed by INH, followed by PZA, Pyrazinamide, and finally Ethambutol. That is the mode of rechallenging according to many guidelines out there. Let's move to the next question, please. And it reads, Mr. BMW was infected with a pan-susceptible strain of Mycobacterium tuberculosis. He has successfully completed 60 days of intensive phase pulmonary tuberculosis therapy. And the team orders a sputum culture, which is positive at 60 days. So my question to you is, which of the following would be the most appropriate course of action in Mr. BMW's case? Would you recommend adding streptomycin, or would you continue intensive therapy and reassess in 30 days? Or would you switch to continuation phase therapy with Isoniazid and Rifampin for 7 months? Or would you switch to continuation phase therapy with Isoniazid and Rifampin for 4 months? I'll give you 10 seconds to choose the correct answer. So I would opt to switch to continuation phase therapy with the Isoniazid and Rifampin and prolong for 7 months. Now, success of therapy for PTB is defined as sputum culture converting to negative at 4 months or sooner. However, the chance of recurrence with 6 months therapy is slightly greater if culture remains positive at 2 months, like in this particular case. And the IDSA guidelines recommend a longer continuation phase, that is 7 months to be specific, rather than the 4 months that is standard, if the sputum culture is still positive at 2 months, like in this particular clinical scenario. So that makes answer C the correct answer. Let's move to the next question, please. And it reads, if the strain of MTB in Mr. BMW's case has been resistant to one of the 4 drugs, which drug resistance would have the greatest impact on the selection of antimicrobial therapy? Would it be Ethambutol, Rifampin, Pyrazinamide, or Isoniazid? I'll give you 10 seconds to choose the correct answer. So Rifampin is the correct answer here. Remember, treatment guidelines for drug-resistant TB recommend drug combinations that differ most dramatically from regimens used in drug-susceptible tuberculosis when Rifampin resistance is encouraged. Now, if INH or PZA or Ethambutol resistance alone is encountered, substitution with 1 or 2 other first-line drugs is recommended to replace the drug exhibiting this resistance. So the situation is more tricky when the resistance occurs to Rifampin as opposed to Ethambutol, Pyrazinamide, or INH. Let's move to the next question, please. And the next question reads, Mr. FTM, a 36-year-old male patient, presents to your clinic, status post lung transplant due to cystic fibrosis. He complains of increasing cough and sputum production accompanied by low-grade fever, weight loss for the past 2 weeks. Currently, he takes 10 milligrams of prednisone orally once daily, 4 milligrams of tacrolimus orally once a day, 400 milligrams of ibuprofen, PRN every 4 to 6 hours, and 100 milligrams of Docusate orally once a day. A physical exam is done, and his vitals are within normal limits except for his temperature, that is 100.3 degrees Fahrenheit. He weighs 70 kilos, and crackles are heard using the stethoscope in the right middle lobe. Otherwise, all other things are within normal limits. A chest x-ray is done and it shows nodular infiltrates in the right middle lobe. And the sputum test is done and it is positive for acid-fast bacilli. The team goes ahead to do an NAAT, which turns negative for Mycobacterium tuberculosis, but it's positive for M. avium. So my question to you is, which of the regimens listed below would be the most appropriate for patient FTM now? Would you settle for clarithromycin, or would you treat with Isoniazid plus Rifampin, or would you treat with Isoniazid plus Rifampicin plus Pyrazinamide, or would you treat with Rifampin plus clarithromycin plus Ethambutol? I'll give you 10 seconds to choose the correct answer. I would treat this fellow with Rifampin plus clarithromycin plus Ethambutol. Now, because of possibility of macrolide-resistant M. avium, initial therapy of pulmonary disease combines clarithromycin with 2 other antimycobacterial agents, not one. So that disqualifies the other options, leaving us with D as the correct answer. Now remember, Isoniazid does not exhibit any activity against Mycobacterium avium. So that makes both answers B and C incorrect. Let's move to the next question, please. And it reads, if patient FTM had been diagnosed with pulmonary infection due to Mycobacterium abscessus, which of the initial antimycobacterial therapies listed below would you have considered the most appropriate for this patient? Would it have been clofazimine plus clarithromycin plus imipenem, or would it have been Isoniazid plus rifampicin plus tigecycline plus clarithromycin, or would it have been amikacin plus tigecycline plus imipenem cilastatin plus clarithromycin, or would it have been rifampin plus clarithromycin plus ethambutol? I'll give you 10 seconds to choose the correct answer. So the best choice would have been amikacin plus tigecycline plus imipenem cilastatin plus clarithromycin. Remember, M. abscessus is a rapid grower, and conventional anti-tuberculosis drugs are limited in value when it comes to managing such infections, and combination therapy is used due to the likelihood of resistance to one or more drugs. That is the main reason why I would go for C, amikacin, tigecycline, and imipenem cilastatin plus the macrolide clarithromycin. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you all in the next video. Thank you very much.